Dr. Azizur Roman for your nice introduction. I am very much pleased, glad, and also happy to present my topic, my talk, in presence of this August gathering, including my professor, Professor M. Nazrul Islam Sir. He is my direct teacher, and I work under him as resident physician and also the assistant professor in 2000 and 2001. Assalamu alaikum, sir, and also the learned panel of experts, Professor Tiptish Chandra Ghosh, Professor of Cardiology, ex-principal and Head of Department of Cardiology, Moinamoti Medical College, Professor Prabir Kumar Das, Professor and Head of the Department Cardiology, Chattogram Medical College, Dr. Sujit Pal, Professor and Head of the Department of Medicine, Chattogram Medical College, Professor Dr. Mohammad Rezaul Karim, Professor and Head of the Department of Medicine, Kuala Medical College, Professor Dr. Hezbollah Zibon, Professor, Department of Medicine, Sylhet Emizi Osmani Medical College, Saleh Ahmed, Senior Consultant, 250-bedded Hospital, Chatpur, and Dr. Korimul Huda Shirazi, Assistant Professor, Department of Cardiology, Abdul Malik Medical College, Noakhali, and also my moderator, my student, Azizur Roman, Assistant Professor from Department of Cardiology, Sylhet Emizi Osmani Medical College. Assalamu alaikum, very good afternoon, and this is Professor Muhammad Shahabuddin, Professor and Head of the Department of Cardiology, Sylhet Emizi Osmani Medical College. Today I am going to discuss regarding the treatment option of hypertension, that is the optimizing the drug selection in hypertension, evidence-based management of hypertension. For the easy understanding of this topic, I have divided my topics into three parts. First of all, an overview of hypertension. Second part, the management strategy that is suggested by different guidelines. And third part, the basis of the choosing of these drugs in different trials. So first of all, introduction. As you know, that rate blood pressure continues to be the biggest contributor to the global burden of the disease and global mortality, leading to 10.8 million deaths each year. And regarding the definition of the hypertension, it has a little bit changed from the previous concept that was proposed by American College of Cardiology in 2017. And it was a little bit changed in 2018 guidelines by the European Society of Cardiology. Now, in 2020, that is the International Hypertension Society, they have proposed the hypertension definition based on the OPISH blood pressure, ambulatory blood pressure, and home blood pressure monitoring. If we consider the OPISH blood pressure, if the systolic blood pressure is equal to or more than 140 and or diastolic blood pressure equal to more than 90 millimeter of mercury, it should be considered as hypertension when it is taken on repeated several clinical OPISH visit examination. And if we take the home blood pressure monitoring, is this threshold a bit lower, that is on 35 and or equal to or more than 85 millimeter of mercury. Again, there is ambulatory blood pressure monitoring. In challenging cases, when the diagnosis is still in doubt, either white coat hypertension or mixed hypertension, in that scenario, the ambulatory blood pressure monitoring may help us. And if we take the 24 hours average, it is on 30 and 80 millimeter of mercury. And daytime awake blood pressure, it is on 35 and 85 millimeter of mercury. But when we consider only the nighttime average blood pressure, it is equal to more than 120 and or 70 millimeter of mercury. So the threshold for diagnosing the hypertension is different depending upon the OPISH blood pressure, home and ambulatory blood pressure monitoring. And this is the classification of the hypertension. It has also been changed from the previous guidelines. Previous guidelines, when it was designated at hypertension from 130 to 139, now it is considered as high normal blood pressures. The ISS 2020 guideline, they have proposed a guideline that should be used They has advised to use it globally, either for the highly economic countries, also the low or middle economic countries. That is, it is global for use of this hypertension guideline. And they has recommended the normal blood pressure as all less than 130 and diastolic 85, high normal blood pressure 130 and 139, and or diastolic blood pressure 85 to 89 millimeter of mercury. And they have designated grade 1 hypertension 140 to 159, and or diastolic blood pressure 90 to 99 millimeter of mercury. And it is grade 2 hypertension, it is more than 160 millimeter of mercury, and it is 110 millimeter of mercury. They have classified hypertension in this way, and they have also fixed the target for reducing the blood pressure to a specific goal according to the age and sex. They have divided this classification into two parts, and one part is essential and one part is optional. As we go in this subsequent slides, we will discuss about this optional and the essential things. This is the various risk factors as associated with the development of hypertension, which ultimately leads to the increased risk of development of cerebral and cardiovascular disease. As we know, that age is a very known risk factor. As the age increases, the prevalence of hypertension increases. It is about 70% if the age goes to 75 years. And positive family history, genetic factor, educational status, socioeconomic status, race, ethnicity, and the poor dietary habit, that is high in salt, low in potassium, high in fat, and excessive alcohol intake can lead to hypertension. And the higher the BMI, that is, if the BMI is less than 25, there is prevalence of hypertension is only 15%. But if the BMI is more than 30 per kg per meter, it is about 3 times more, that is nearly about 42%. So BMI has a positive role on hypertension, psychosocial stress, diabetes mellitus, physical inactivity, and tobacco use. And also sex, that is, if it is more than 60 years, greater in women, if less than 60 years, then greater in men. All these risk factors ultimately leads to stroke, coronary artery disease, left ventricular hypertrophy, peripheral arterial disease, heart failure, and chronic kidney disease. So treatment of hypertension can also leads to reduction of the stroke, cardiovascular, and the peripheral heart failure and chronic kidney disease. This is the pathophysiology of the hypertension, that is impaired renal function, inappropriate activation of the hormones that regulates the salt or water excretion by the kidney, and excessive activation of the sympathetic nervous system. All together impaired the renal pressure matrices that leads to hypertension. This is the proposed treatment option, that is effective treatment option includes two parts, that is lifestyle intervention and pharmacological management. Among the lifestyle intervention, weight reduction, improved diet, increased exercise has positive role, and also the cessation of smoking. Though direct cessation of smoking has no effect on reducing the blood pressure, but it also prevents the cardiovascular morbidity and mortality. And use of the treatments, pharmacological drugs, that is use of the treatments from 1 to 3 of the following drugs: diuretics, renin-angiotensin-aldosterone blocker, either ACE inhibitor or ARB, calcium channel blocker, anti-adrenergic drugs, and direct vasodilators. The recommendation is use of 1 to 3 drugs for the better control of the symptoms. And optimizing the drug selection in hypertension, we will discuss on the RAAS blockade, and second part we will discuss on its combination. Why will we discuss on RAAS blockade? As because the most of the guidelines based on the RAAS blockade and its combinations. Later we'll see what is that. Why we will focus on RAAS blockade? Because RAAS blockade concludes two things, that is the angiotensin converting enzyme inhibitor and the ARB. What is the difference between the angiotensin inhibitor and the RAAS blockade? It is simple, that is the potentiation of the kinase system. that was absent in ARB, but it was present in angiotensin converting enzyme. In simple word, angiotensin converting enzyme acts by inhibiting the conversion of angiotensin 1 to angiotensin 2. So there is an imbalance between angiotensin 2 and the increased level of bradykinin, as because the ACEi inhibitor, that is angiotensin converting enzyme, also deactivated or degraded the bradykinin. As this enzyme is inhibited, there is potentiation of the kinin system. So ACEi inhibitor is a dual actions. It's also there is reduction of the angiotensin 2. At the same time, that is potentiation of the kinin systems. This kind of systems has positive roles on the cardiovascular system, that it increases the nitric oxide and improves the endothelial dysfunction. These two things contributes its superiority over the ARB. And the bradykinin angiotensin selective ratio, it is 1.4 in PERINDOPRIL, but it is not same in all the ACEi inhibitors. That is why all ACEi inhibitors are not same. It is Remifil, it is 1.6 and it is equivalent, and 1.9, and in enalapril it is 1. So PERINDOPRIL protects the endothelial dysfunction by more vasodilation without changing in COP. So all the there is a question, all the ACEi inhibitors are same. No, all the ACEi inhibitors are not same, as because they are different in their molecular structure, difference in their potency, different bioavailability, plasma half-life, and tissue affinity. So all these things together, they are different in their structure and the functions. Now, the guideline recommendation. What are the guideline recommendations for the treatment of hypertension? There are so many guidelines. In 2017, that is ACEi guideline, 2018, ESC guideline, 2019, NICE guideline, also the Japanese hypertension guideline, and recently, this is 2020, the ISS guideline. I will discuss separately all of these guidelines in very briefly. In 2017 guidelines, they recommended 4 drugs as a class of 1 recommendations for the treatment of hypertension. That is the diuretics, calcium channel blocker, ACEi inhibitor, or ARB. What is the recommendation of these drugs in 2018 ESC guidelines and 2020 guidelines for starting the single pill combination initially? The backbone of this trial is 2 trials, that is a ASCOT trial, which includes PERINDOPRIL and amlodipine, and a accompanying trial, which is not available in Bangladesh, that is benazapil and amlodipine. Both these trials are the backbone of ESC 2020, ESC 18 and ISS 2020 guidelines. Both includes ACEi inhibitor and calcium channel blocker. And in 2018 guideline, ESC guideline, they have proposed this combination for pharmacological management. Initial step 1 pill, that is dual drug combination, ACEi inhibitor, or if it is not tolerated, ARB plus calcium channel blocker or diuretics. Step 2, that is triple combination, ACEi inhibitor or ARB, calcium channel blocker or diuretics. And in step 3, that is 4 drug, triple drug combinations plus spironolactone, especially it is designated for resistant hypertension. They have also proposed the single drug combination, especially for stage 1 hypertension, when the blood pressure is less than 150 millimeter of mercury, or very old frail patients. In that scenario, they have recommended the single drug combination, single drug. But the basis for choosing the ACEi inhibitor and the calcium channel blocker in these guidelines are based on the ASCOT trial. That is on the COVARUM, COVARUM and type of hypertensive patient. It reduces the 16% cardiovascular events, and people was significant. In counterpart, when the calcium channel blocker was added in angiotensin receptor blocker, in COPE and CHROME trial, they have failed to show any significant difference in cardiovascular outcome. So ARB and calcium channel blocker cannot reduce the cardiovascular events. This is very important and very crucial things that it should not be started with ARB and calcium channel blocker as the initial combination for treating the hypertension, as because ESC-28 guidelines found no trial on ARB and calcium channel blocker with significant result in cardiovascular protection. And there are several trials that have compiled all together in ACE inhibitor and calcium channel blocker versus ARB plus calcium channel blocker, and total number of patients was 70,000 in ACE inhibitor and calcium channel blocker, and only 8,000 in ARB and calcium channel blocker. So you can easily understand from the accomplished ASCOT INVEST and NODIL trial that was show its efficacy when reducing the cardiovascular events over the competitors. Now the guidelines, that is latest guidelines 2020 is International Hypertension Society guideline. They have they have proposed two things. One is essential and another is optimal. They have proposed the thresholds for and their targets. And essential targets target blood pressure reduction at least 20 to 10 millimeter of mercury, ideally less than 140/90 millimeter of mercury. And optional, if it is less than 65 years, blood pressure target should be less than 130 to 80 millimeter of mercury if tolerated, but no more than less than 120 millimeter of mercury and 70 millimeter. So blood pressure should be more than 120 and 70 millimeter of mercury. But if it is more than 65 years, the blood pressure target should be less than 140/90 if the patient can tolerate it. And again, they have recommended that the aim of blood pressure control within 3 months, not to hurry, not to fast, not to, except in a special situation of hypertension, urgency, and emergency. So once the hypertension diagnosed, it should be started with lifestyle modification in grade 2 hypertension if it is associated with 160 to 100 millimeter of mercury. In addition to lifestyle modification, we will have to start the drug treatment. We will be subsequently discuss in next slide. But in stage on hypertension, when blood pressure is 140 to 159 and diastolic blood pressure is 90 to 99 millimeter of mercury, this portion, if this portion of patient is associated with high risk, that is CVD, CKD, diabetes, or hypertension-mediated target organ damage, this group of patients, though it is grade 1 hypertension, should be treated like grade 2 hypertension, that both pharmacological and non-pharmacological way. But if the grade 1 hypertension is associated without any risk factor with low risk group, they should be offered for non-pharmacological management for 1 to 3 months. If non-pharmacological management fails to control the blood pressure to a desired level, then pharmacological management should be offered. And what is the pharmacological management? It is again optimal and again essential. The sequence of pharmacological management as proposed in ISS 2020 guideline is step 1, low dose combination. That is a bit changed from the ESC 2018 guidelines. They have recommended initial dual, that is low dose combination, step 2, dual full dose combination, step 3, triple dose combination, and step 4, that is resistant hypertension, triple combination plus spironolactone and other drugs. And ideally, a single pill combination should be offered, but there is also some essential recommendation. If single pill combination is not available, so you can use the separate combinations. If non-dihydropyridine calcium channel blocker is not, if the dihydropyridine calcium channel blocker is not available, you can use the non-dihydropyridine calcium channel blocker. If thiazide type of diuretics is not available, you can use thiazide diuretics. And in any stage, beta blocker was not included in these 4 steps, step 1, 2, 3, and 4. But you can add beta blocker in any step if it is associated with compelling indications. That is in heart failure, angina, post-MI, atrial fibrillation, young patient women, or with planning for pregnancy. In that situation, you may add the beta blocker that was recommended by ISS 2020 guideline. And they have recommended as initial combination of ACE inhibitor if intolerant by ARB and calcium channel blocker. And in step 3, the diuretics, they have recommended the diuretics in step 3. Though diuretic is a very old drug and it has started in its treatment in 1966, but in 2020 it has leveled at step 3. Now we'll consider the monotherapy as we have already discussed in step 1, grade 1 hypertension or in very old patients. And you may consider, according to this guideline, the ACE inhibitor and diuretic in post-stroke patient. That was this progress trial, and very elderly, that is hybrid trial, and incipient heart failure or SCCB intolerant. You may consider the ACE inhibitor and calcium channel blocker or ACE inhibitor plus diuretics in black patients. And caution should be taken when using the spironolactone on other potassium sparing agents with estimated GFR less than 45 ml per minute and potassium concentration more than 4.5 millimole per micron. Now, according to this, the latest guideline, they have recommended A, C, and D. A, RAS blockade, C, calcium channel blocker, and D, diuretics. Now, I am going with the last part, that is with the diuretics. And thiazide type of diuretics has this latest evidence in these latest guidelines in ESC 2018, ACC 17, ADA 19, Canadian Hypertension Guideline, and NICE Hypertension Guideline. All these guidelines, they have recommended either fluorothiazide or indapamide as the effective treatment option. But when we compare the BP efficacy and CV protection in 19 meta-analysis of RCT, that is superior systolic blood pressure lowering effects also observed in indapamide rather than fluorothiazides. And there is also reduction of the stroke, cardiovascular events, and heart failure more in favor of indapamide than the competitor fluorothiazide. So, indapamide is the right option to choosing as a antihypertensive drugs as diuretics. And there are other trials that has proved its efficacy in hybrid, that is hypertension in very elderly patient, indapamide plus PERINDOPRIL versus placebo. It has reduced the morbidity, mortality, and also they improved the heart failure. In advanced trial, it is in a diabetic patients, indapamide and PERINDOPRIL has reduced the morbidity, mortality as a total renal protection. That's 21% total renal protection. In progress trial, again, it reduces the more than 40% of strokes and cardiovascular outcomes. This is a very landmark trial, advanced, hybrid, and progress trials. And hybrid trial is so much so important that it has stopped prematurely due to its greater benefit mortality. And PETs, again, in placebo, it has proved its efficacy, that is 20% reduction in strokes. This is only possible as because it has BP lowering effective phase than others, and it's metabolically neutral. It has 24 hours blood pressure controls, and it can prevent the heart failure and stroke prevention. Due to its superiority, due to its potentiality, all these trials have been included the indapamide as a diuretic therapy. Now, some other combinations, that is A and D. That is PERINDOPRIL and PERINDOPRIL combination with amlodipine and indapamide. Evidence from hypertension patients. What are the evidence in hypertension patients? That is the backbone of this choosing the combination, that is ACE inhibitor and calcium channel blocker, is ASCOT. In the ASCOT trial, there is two arms, that is amlodipine and PERINDOPRIL on arm, and another arm is atenolol and benzopyrrolithiazides. Previously, the ZNC 6-7 guidelines, they have the backbone of treatment of atenolol and benzopyrrolithiazides. And they have challenged these drugs, that amlodipine and PERINDOPRIL, this new type of drugs. And they have proved its superiority over atenolol and benzopyrrolithiazides like that. It can reduces the cardiovascular mortality 24%, peripheral vascular disease, that is 35%, stroke 23%, renal impairment 15%, and new onset of diabetes 13%. So in conclusion, perindopril and amlodipine combined significantly provides longer protections. And if we consider all together, so that is Losartan, potassium, Telmisartan, and Coversil regarding the randomized trial of perindopril, enalapril, Losartan, and Telmisartan in overweight and obese patients with hypertension, changes in 24-hour systolic blood pressure more in Coversil's. Conclusions, that is better BP lowering effects compared to Losartan and Telmisartan. Now the another trial that was conducted on hypertension patients by ARB, ACEi inhibitor, or combinations. This is a one-target trial, and this one-target trial, the primary outcome, that is cardiovascular cause, myocardial infarction, stroke, and hospitalization, heart failure, was not significant. Rather, it has created more than 17.5% hypotension and 58% renal impairment. So combination of telmisartan and enalapril is dangerous, as because it causes more profound hypertension and renal impairment. Another effect is it can that is when is compared with telmisartan with ramipril, there is 7% increase in MI with telmisartan, 12% increase in heart failure hospitalization, and 12% more new onset diabetes with telmisartan, and 9% more with renal failure. So the fourth and largest comparative trial on target study confirms beyond doubt that angiotensin receptor blocker ARB are not better than angiotensin converting enzyme inhibitors at reducing the fatal and non-fatal cardiovascular outcomes. So in these are the hypertension in general. Now we consider the patient in stable coronary artery disease. This is a known renowned trial, that is EUROPA. That is it's perindopril on placebo in chronic stable anginal patient. It reduces the cardiovascular death, MI, and cardiac arrest. So all this favor in favor of cardiovascular mortality, non-fatal MI, cardiac arrest, and in favor of perindopril in EUROPA trial. And somebody asks, there is another trial, that is HOPE trial. It was published in 2000, and HOPE trial, EUROPA trial was published in 2004. And most of the time they compare the ramipril with perindopril. But if we look carefully, the HOPE trial and EUROPA trial, there is a quite difference in between this trial. The selection of the patients is age more than 18 years, but in HOPE trial it is more than 55 years, and it was included the more complex patients, that is high risk patient, peripheral vascular disease, stroke, diabetes, and other cardiovascular risk factors. But in EUROPA trial, they documented coronary artery disease and post-MI patients, and more than 70% stenosis. They have included the mild, moderate, and also the high risk patients, but ramipril included only the high risk patients. But the beauty of this trial is that they have excluded the heart failure. That is, it has ejection fraction is more than 40% in both of these groups. And primary endpoint was cardiovascular death, non-fatal MI, and cardiac arrest. But in HOPE trial, they have included the stroke also in addition to MI and cardiovascular death. Number of patients are 12,000 and 9,000. If we see the major difference between HOPE and EUROPA trial, in EUROPA trial, the CAD was 100%, and in HOPE trial, it was 18%. And patient at risk, in EUROPA trial, low, medium, and high risk group, but in EUROPA HOPE trial, it is high risk group. And primary endpoint reduction more with cardiovascular death, MI, and stroke was 22%, as because they have included stroke as a primary endpoint. But in EUROPA, they have not included the stroke as a primary endpoint. So cardiovascular death, MI, and cardiac was 22%, but p-value was significant on that. Reduction of hospitalization for heart failure, p-value was not significant in HOPE trial, but it was significant in EUROPA trial, that is 39% reduction hospitalization. If we consider directly to HOPE and EUROPA trial, there is a reduction of myocardial the meta-analysis of reporting the effects of ACE inhibitor in patient without heart failure. That is a regression of MI. In HOPE trial, it is 19%, but in EUROPA, it is 28%. If we consider the HOPE and EUROPA direct head-to-head comparison, it is 43% better MI risk reduction compared with Remipril. So copper still provides better protection. And evidence in acute MI, it's also the pre-MI evidence, that is a patient with MI with left ventricular ejection fraction 40% or higher, and death, MI, and remodeling was cardiac remodeling was favored in cover seal group. Evidence in diabetic hypertension parallel, this is a landmark trial that is it's a combination of PERINDOPRIL with indapamide, and there is reduction of cardiovascular mortality and morbidity. That all-cause mortality was reduced 14%, and cardiovascular death was reduction is 18%. And evidence in strokes, there is again landmark trial of progress versus indapamide plus PERINDOPRIL. There is 43% reduction in stroke. If we consider individually, that is 36% ischemic stroke and 76% on the hemorrhagic stroke. So combination of PERINDOPRIL and indapamide or active treatment group provides better protection. But when this trial was conducted with Telmisartan, the Telmisartan provides no better protection. Telmisartan demonstrated no significant benefit over placebo in the rate of recurrent stroke. That is progress trial. And other trials that has been used in combinations. Hypertension in very elderly, we have discussed it, that is PERINDOPRIL plus indapamide versus placebo, 34% reduction of cardiovascular events. Hypertension with non-diabetic kidney CKD. Renin trial, that is ACE inhibitor versus placebo, again p-value significant. ASCOT trial, here ACE inhibitor, diuretics, and alpha blocker was tested again. Calcium channel blocker, diuretics, and alpha blocker. There is the 39% reduction in the renal impairment. P-value was significant. Hypertension in diabetic nephropathy, it is ARB versus CCB. 23% reduction in renal impairment, and BB reduction for secondary prevention of cardiovascular events in this trial. P-value was not significant. Here, verapamil and plus ACE inhibitor was tested versus beta blocker and diuretics. And hypertension with left ventricular hypertrophy, that is light trial, this is landmark trial by which the Losartan potassium becomes its license for the treatment of hypertension, in which diuretics plus ARB versus beta blocker and diuretics, they have shown that 37% reduction in cardiovascular mortality. So, considering all this evidence together, we can say that the influence of morbidity and choice of the antihypertensive drugs, ACE inhibitor, can be used in compelling indication like heart failure, left ventricular dysfunction, post-MI or established CAD, type 1 diabetic nephropathy, as secondary stroke prevention. Also the possible intervention of chronic renal disease and type 2 nephropathy. But caution should be taken for renal impairment, peripheral artery disease, and it is contraindicated in pregnancy and renovascular disease. Now, regarding the angiotensin 2 receptor blocker, when ACE inhibitor intolerant, type 2 diabetic nephropathy, hypertension with left ventricular hypertrophy, heart failure in ACE inhibitor intolerant patient after MI, and possible indication is left ventricular dysfunction after MI, intolerant after antihypertensive drug, proteinuria or chronic renal disease, or especially in heart failure. Now the evidence in favor of mortality. If we consider the meta-analysis of ACE inhibitor ARB, that is RAS blocker, that's mortality in favor of ACE inhibitor in hypertension, diabetes, CAD, and high-risk patients. If we consider the ASCOT trial, that is the primary, secondary, and tertiary endpoints are in favor of ASCOT trial, that is calcium channel blocker and indapamide. Only two things that does not favor it. Number one, silent MI, it was not favored in this trial, and the life-threatening arrhythmia. And another trial, that is roadmap trial, that is a treatment of hypertension diabetic patients with Losartan, that reduces, that prevents the new onset of microangiopenia at the cost of increased mortality. And so, the only things that we are not using the ACE inhibitor, that is its complication, that is cough. The rate of cough during the treatment with angiotensin converting enzyme inhibitor, a meta-analysis of randomized placebo-controlled trials. They have reviewed the 22 RCTs. Result reported on the coughs that 13% on the ASC, 18.5% on placebo versus. When placebo adjusted, 63% of cough causes on ACE inhibitor are potentially not caused due to ACE inhibitor. So there is a lot of, that is 2/3 of the cases of the coughs origin is not due to ACE inhibitor. So conclusion, other than causes of the cough should be excluded before ACEi withdrawal, and re-exposure to ACEi should be carried out before continuous withdrawal or replacement of ACE inhibitor, especially in patients with heart failure. And the rate of cough lowest with PERINDOPRIL, that is in comparison to lisinopril, captopril, enalapril, benazafil, ramipril, and others that was not also available in Bangladesh. It was a randomized Bangalore meta-analysis trials. It includes 125 meta-analysis, nearly about 2 lakhs of patients. If we consider all this meta-analysis regarding ACE inhibitor and inhibitor, the composite outcome was in favor of ACE inhibitor in relation to cardiovascular death reduction, more in ACE inhibitor, MI, stroke, all-cause death, new heart failure, and new onset of diabetes. So all data in favor of ACE inhibitor, not the ARB. So in conclusion, consistency in favor of ACE inhibitor shown on large scale trial. ARB are missing where ACE inhibitor success in several trials. In advanced trial, that is a landmark trial in diabetic patients with PERINDOPRIL and indapamide versus placebo on the top of the standard therapy. Hybrid trial, that is hypertension in very elderly, indapamide PERINDOPRIL. This trial was prematurely stopped, as I have mentioned earlier. HOPE trial, ramipril versus prepral, is a good trial that has reduces the primary endpoint, cardiovascular mortality, and all-cause mortality. But when it compared with PERINDOPRIL, it's lost its superiority over the PERINDOPRIL. Transactional data is not available. In progress, PERINDOPRIL and indapamide versus placebo, it reduces the primary endpoint, that is, it reduces the stroke upon 43%. And PROPES trial, that is, it does not show any significant difference between the placebo. So treatment with telmisartan does not produce or reduces the primary endpoint as strokes. Now, in summary, which drugs for which patients? There is generally a consensus that at the end of the day, vast majority of the hypertension patients, regardless of the age, race, ethnicity, and absence or presence of target organ damage or comorbid condition, will require triple combination drug therapy with a calcium channel blocker, diuretics, and ACE inhibitor or ARB. So the only issue is the which drug or drugs to be prescribed first. In ISS 2018 and ISS 2020 guideline, paper both ACE inhibitor and a combination of calcium channel blocker to initiate therapy in general patient with hypertension. Most guidelines prefer both thiazide and calcium channel blockers over ACE inhibitor or ARB to initiate therapy in black patients. There is overwhelming consensus that ACE inhibitor or ARB is the first-line antihypertensive therapy in patients with diabetes. There is also overwhelming consensus that ACE inhibitor or ARB is the first-line antihypertensive therapy for patients with CKD. So there is a conclusion from more recent trials that the US FDA has labeled telmisartan as like the use for CV reduction if unable to take ACE inhibitor, as because the PROGRESS trial has failed to show its consistency with the reduction of the strokes. So they have labeled telmisartan when ACE inhibitor is not able to take. And 2013 ACC, AHA, and CDC guideline stroke and TIA thiazide and ACE inhibitor, and CAD post-MI beta blocker and ACE inhibitor. In 2013 ESC guideline, ARB inferior to ACE inhibitor in preventing MI and all-cause mortality. And Thromboplast, that is a meta-analysis in 2015, that ACE inhibitor, not ARB, reduces MI, CVD death, and all-cause death. And 2017 ACC-AHA guideline, CKD and hypertension, ACE inhibitor first, post-stroke ACE inhibitor and diuretic combination first. And 2019 guidelines for chronic coronary syndrome, hypertension, left ventricular ejection fraction reduction, and diabetes or CKD, ACE inhibitor first. And in ESC 2018 and latest the ISS guideline, ACE inhibitor and PERINDOPRIL, the initial choice. So all these trials goes in favor of ACE inhibitor and its combination PERINDOPRIL and also the indapamide. So I am at the end of my presentation. That's take-home message, that is globally 30,000 deaths per day are due to raised blood pressure. So we must improve the screening and management of the hypertension. BP lowering efficacy of RAS blockade varies and is drug specific. Long duration action is crucial. COP is a common condition, sometimes caused by ACE inhibitor. That is not a reason to avoid using ACE inhibitor, as because they save lives. Overall, the best evidence and many guidelines suggest ACE inhibitor should be used ahead of ARB to prevent death and various cardiovascular events. And this is the final slides. That's if we consider all together, that is COVARSIL 4 to 8, COVARAM 4.5 to 10, and COVARSIL 5 to 10. The trial is like that. If we consider the diabetic patient advanced trials, it has proved its efficacy in diabetic patients, that it reduces the cardiovascular mortality about 18%. If we consider ASCOT trial in general population, it reduces the mortality about 24% with ACE inhibitor and calcium channel blocker. If we consider the stable coronary artery disease, that is COVARSIL 4 milligram, it reduces myocardial mortality, MI, and cardiac arrest 22%. If we consider PROGRESS trial, that is a stroke, it reduces the strokes nearly about 43%, and secondary stroke 28%. If we consider in MI, it reduces the heart failure, death, and cardiac remodeling 22%. And in heart failure, trial death and heart failure is reduced by 31%. So in all aspects of cardiovascular continuum, that is in high risk group, in hypertension patient, in CAD, in MI, in post-MI, in heart failure, in all raises the ACE inhibitor, that is COVARSIL provides its better protection alone or in combination with ACE inhibitor or PERINDOPRIL. Thank you very much for patient sharing. Now I like to conclude my topic here. Thank you very much for patient sharing.